part marking, and you're going to see a lot of technology today. Our healthcare background, it's pretty, we got involved with the VA hospital about 7 years ago, and their challenges for asset tracking, and our background is we've deployed passive RFID, and we have a team of people that have tagged over 200,000 assets, hospital assets at 15 VA medical centers, and we've learned a lot, and we're going to be sharing some of that today. We're excited about the technology and solutions, and we're here to answer questions and be part of the discussion. Please keep it wide open. There's experts in this room, and one of the things I'd just like to kind of overarching from being in this industry for 27 years is the improvements of especially what we're going to talk about, some of the passive RFID technology has improved so much, especially in the last, say, 3 to 5 years. And I know the Zebra team and, working in retail, and we have Walmart now. I think there'll be some case studies coming up, UPS, and healthcare and metal parts and liquids. And we work with the FDA, and we've rolled out RFID tracking at 4 research labs, tracking chemicals, solvents. We couldn't have done that 3, 4, 5 years ago. So it's just really exciting. And now healthcare, the timing is great, for med device, for tracking metal items, equipment in hospitals. And this technology is ready for prime time. So that's, we'll give you a little teaser.
Yeah, I love it. And for those of you who may not be ultimately familiar with Zebra, as Gary mentioned, we are the #1 provider globally for RFID solutions. And so while healthcare may be newer and actually starting to sell or actually buy and utilize RFID, this technology, as Gary mentioned, and our experience in the various industries lend themselves very well to what we're trying to accomplish here. And so my ask is what Gary was talking about earlier. Let's make this a dialogue. We want to make sure that you get the most impact from today's content, and that really starts with you. So if you have a question, stop us. We'll talk about it. We'll address it. If we don't know it, we'll put it in the parking lot and we'll get back to you. But hopefully through the agenda that you see today, we've got a lot of value packed into this. So this is for you. Let's make it for you. So if you have questions, please ask that. Gary, anything else on your side?
No, I'm good. I'm anxious to get going.
Yeah, awesome. Derek, who am I turning it over to now? Okay, Cassandra, come on up. I feel like I say that all the time, Cassandra. You and I are we're on the same page everywhere. All right, folks, thank you all. Appreciate you.
Good morning, everyone. My name is, how y'all doing? Great. My name is Cassandra McKnight Young, and I'm the Chief Nursing Informatics Officer here for Zebra Technologies. And we're at the Track and Trace Summit today, right? And you're probably figuring out or trying to figure out, what am I doing here? Because that's exactly what I thought when Derek reached out to me, right? I don't care where Xavier is. I believe his second job is MC. But one thing I do have to tell you guys, that I stood in this room back in 2018 as a Zebra client, talking about clinical mobility, of course, and different things like that. But what I really want to say is I can talk about clinical mobility, right? Because that's my wheelhouse. And I'm always saying why I do love Zebra and one thing I like about it, because I can be my authentic self. And so this is the perfect opportunity for me to be my authentic self, because RFID, RTLS, tracking inside the 4 walls of a hospital is not something that we're comfortable with. This is a very uncomfortable space for me. And so I wanted to share that to say, how can we change it? How can we make it comfortable for people inside of the 4 walls, for clinicians, and what does it really mean for them? My opening slide, I'm talking about healthcare strategic growth opportunities. And I took it back to the floor nurse, because for me, what matters to me is freaking, where's my bladder scanner? There's a lot of opportunity out there, but what does it really look like and what is that impact? Currently, this is what we're dealing with. This is not anything new, first of all, to healthcare. It's new to the world, but to us, it's what we've been dealing with for year and year after year. Of course, there's new regulations that's involved, that's the margins are getting even tighter, and then you are dealing with clinicians leaving the bedside, not just nursing, but everybody's leaving the bedside or leaving bedside care. And so with that, with people leaving, you don't have the skill set that was once there. You think about that. So not just a staffing shortage, but the actual critical skills that's there. So these are all the challenges that are facing in healthcare today. And all of those things really contribute to a couple things. Bottom line, dollars. And how does RFID, RTLS play in that, and what is the impact of it financially? 2.4% again has the margins have gone down as far as spending. Okay, that's a decrease by 7% since 2019. Hospitals are wasting between 30 and 50 billion dollars in avoidable hospital waste. I'll break that down here in a minute. And then on average, it costs anywhere from $50,000 to $80,000 to just replace a staff RN. That's not a specialized RN. That's just the average. That's not a physician. That's probably really low in reality. That's why the wide range. But these are the challenges. But let's go deeper into the avoidable hospital waste, because that's what we all want to do, because they all impact those things I talked about. $25 billion are being spent alone when it comes to supply chain inefficiencies. Now, let's take that back to me as the floor nurse. Why do I care that we don't have supplies? I can't take care of my patient. It directly ties back to patient care. It ties back also to clinician burnout too as well. Because if I have to go around looking for medications or whatever it is I'm looking for and I can't find it, or we don't have it because it's expired or whatever, that is a dissatisfactor for me. The second thing about that is financially, when we run out of supplies, we may have to use a different type of supply that may cost the hospital more money. So for example, let me put it on a level. If we're giving a dose of pain medication that is normally a 1-dose vial and it's 1 meal in there, and that's what your order is for, then I can give you that. But if we ran out of 1 meal vials and now the only thing there is 2 meal vials, guess what? We don't take that 1 meal out and save it later. You know, we do it, we throw it away. So that's when I say wasted medication, that's where that number can come from, because I'm going to throw away. We don't do like we do at home, wrap it back up and then come back and get it later. It does not work like that because of infection, and we're going to enter that vial one time. Okay. And then duplicate purchases, right? Because y'all know what happened. You can't find it. You need it. We just going to buy it again. And then 5 months later, you yelling at your kid because you know they moved it, and now you done bought it again. So wasted money. Same thing in the hospital setting, but bigger impact, right? $800 million on expired drugs in hospital pharmacies alone is the second chunk of money. I just explained to you a couple things, but also if you have these medications and you don't know when they expire, y'all know what I'm talking about. You do it all the time at home. You buy that lettuce because you're going to make that salad because you're working out and you're going to get healthy. And every time you go to the refrigerator, you're not going to eat that. And then you come back and it's gone bad. I mean, that's the reality. It's the same concept, right? or somebody did not move something from the front to the back. It's how it goes. So just think about that in a hospital setting, because manual processes, I talk about this all the time, is I should have put on do not disturb. People do not leave me alone at this job. They don't. But understand that. So it's the same concept. And then 15 to 80 minutes of $15 to $80 per minute on OR time costs. What does that mean? It's already bad when you call and they tell you not to drink or eat before your surgery. And then when you call in, you be like, oh, you literally meant that. And we say, yes, we cancel that surgery. That cost us money. Same concept. If we don't have the supplies, we don't have the right staff, something's expired, same concept. So that is, and it's 1,000 to 10,000 plus per case. So you think about that. That's how we got to that $30 to $50 million. Okay. This last one is priceless. This is what you all call a return on investment. I call it return on life. This is why everybody in this room should care, other than the pipeline they're trying to grow, is when we need something, or if I need you, or I need a piece of critical equipment, I don't have time to go looking for it. Or I don't need to be leaving my floor to go look for my bladder scanner for 20 or 30 minutes, because two things. The most important things, I have patients that are there that need me. So if during that time while I'm lollygagging around the hospital looking for a bladder scanner, somebody could be decompensating. And what nurse knows more about the patient that they're taking care of? That nurse that's taking care of them. If I'm down the street on another floor looking for a bladder scanner, that patient is in trouble. It's just that simple. Okay. So do I need to be doing time doing that? I do not. Second of all, I'm mad at you now, because what? I can't find what I need. I'm tired. My mind is racing. 34 additional cognitive overload. Stop asking me why I gave the wrong medication, or why I did not do this or that, or change your mom's bed. It's because I can't find the things I need, which adds to the frustration. I have my backpack, Zebra. You see that over there? I mean, I need my backpack to carry my items, but really I talk about the nursing backpack, and this is a contributor right here. So on top of me documenting up to 41%, I have to look for items. I have to put all these hats on. I got to remember what I do. Since COVID, dietary, don't go into certain rooms. So I got to go in there and be the dietary person. There's certain equipment in there that I got to go move out, because the rooms need a special cleaning. And so, do you understand what I'm saying? It's not just I'm going to take care of my patients. So critical asset tracking is very, very important. Not just to the people who are looking at the big dollars, but even to the nurse impact, which we're contributing to while we have left the bedside. And you think we are actually taking care of doing customer service? You know what? We're driving trucks. We're not even doing anything more customer facing anymore. The impact is good. And when all of you get older, somebody is going to need to be there to take care of you. They're correct. This is why we have to help do whatever we can to really help the clinician burnout, improve the patient experience, and then cut that bottom dollar. Those resources. And what it is, I tell people all the time, stop saying you ain't got no money. And that's that Cassandra drawl from Arkansas. Stop saying you ain't got no money. You got some money, you wasting it. or it's not being used in the right resources. Okay? $1 to $5 million per year is wasted labor and inefficiency. Is that it? Thank you. We can call the next person, which I think is actually me again. And Boyede.
So I get the pleasure of co-presenting with Cassandra. Thank you, everybody. Also, I want to take the opportunity to, I'm sure we're going to do it at the end of the day, but also acknowledge Derek for kind of helping to kind of coordinate everything, put this all together. This is an event that we had last year, as I said. So last year was kind of our V1. So this is a market step up far as the previous year. So just to kind of go into it, my name is Boyede Sobaton. I serve as Zebra's global healthcare vertical strategy lead. So we're going to talk about AI and the applications of AI within the RFID space and how we are evolving it. So okay. Yes.
Cassandra, I had one question, and I've heard this. Do you know, I mean, we've heard horror stories about, patients being in surgery and even in the ER, how critical having equipment is for outcomes, right? Minutes, right? And strokes. But we've heard patients being open on the operating floor. The surgeons, once he sees something he needs to do, procedure, and like you said, you can't find something, right, in the OR. I mean, does this happen a lot? Or, I mean, is this like, you're under anesthesia. I heard one story that a patient, they're looking for this monitor or the scope, and they're sitting there for 20 minutes under anesthesia while the surgeon's working on another, and then he comes back. They couldn't find it, and they had to, is this
so,
they probably don't report it. I'm just concerned about, like you said, our personal health care, right?
Yeah. Of course, I still work the floor. I'm still a nurse, but sometimes I look at cases, situations that's happened. And when I'm talking, don't nobody look up where I work or where I used to work. But coming from an informatics side, I sit on every root cause analysis that happens in the hospital. And the stories I can share with you will have you shaking in your boots. To save somebody's life, they came in, for example, shooting, and then to leave something in the patient that almost cost his life. So we save your life to try to kill you. Do you understand what I'm saying? So absolutely. Do I think everything gets reported? Absolutely not. Is everything invested? It is, but based on whatever regulations it is at the hospital, whatever they're doing, they will report that, or they work out a procedure to prevent it from happening again. In hospitals, this is the problem. We are reactive instead of being proactive. And yes, do I think a lot of bad things happen and could have? Absolutely, they do. But sometimes, let's talk about the patient experience. How do we lose a whole dead body? Ask me. How do you do that? How does a patient go to the morgue and then they ain't in the morgue no more? Or as a mother who just lost their child and now they want to come collect their child and we don't have any idea where that child is. You know what could have helped that? Tracking, right? Do you understand what I'm saying? So, and everything I share with you is something I've experienced. So, talk about that patient's experience. Can I put a dollar amount on that, the anguish that somebody was looking for their loved one and we don't even know where the patient was? Okay, so yes. And thank Boyede for coming up here. This again shows you, I know people, I don't need any help presenting. I do not. Okay, if anybody can tell that I'm very comfortable doing that. But he is, who am I to you? Come on, tell him my story before we get started. So I want them to know that I had to call on you today.
Okay, so we have a running joke between ourselves. So you like basketball, I consider myself Pippen, and she. So I throw up the alley oops, and she comes down with the ball. So that's kind of how it is. And I also like to mention she. Oh, you're Jordan. Right there, just but also like to also for a fun fact, she actually is related to Scottie Pippen. So just a genuine fun fact. So I'm not sure if she got dinner with him yesterday. I know he's around in the city of Chicago. So yeah, so it's not to lighten up because that was a very heavy explanation of what goes on. But also, I'm a registered nurse as well, and I also moonlight every other weekend as an administrator at a large inner city hospital here in Chicago. And the track and trace issue, I see it on a monthly basis. I mean, something as common as we don't have a bed in this room, like a hospital bed in this room. So let me see if I can help you.
I'm going to do that disturb. I'm sorry.
Okay.
I should have been doing that while I was over here playing around.
So yeah. So just even something as simple as a hospital bed, or hey, we have a patient that needs to go to this room and we can't find a wheelchair to take the patient up. So again, a lot of these things have sometimes sound very theoretical, and sometimes we kind of get so high on the art of the possible that we don't really get into the science of the actual. So this is what we're trying to really accomplish here with a lot of the things we're talking about today, and we have a couple of partners here who have actually actualized a lot of the things that we prescribe and talk about here at Zebra. And one of the things we want to talk about is AI. Now, I know AI means a lot of different things to a lot of different people, depending on your technical proficiency. So it's going to be something as simple as Chat GPT, and some people are talking about RAGs and LLMs and all those different things. So we're going to try to simplify it as much as possible. But one of the things that is essential to any kind of AI or machine learning is the data inputs. So if you don't have a base layer of how to get the data, then the conversation about AI is really irrelevant. Let's get the basics down first. So this is what we're going to hopefully convey with some of the things that we're doing here at Zebra and how we kind of visualize AI as the element, the ability for us to acquire the data and to make sure the data is in the right place, can be digested effectively. And then how do we kind of move from what Cassandra mentioned, from being a reactive organization to more of a proactive organization? So that's how Zebra from AI from a frontline, that's how we visualize it. That's how we talk about AI from the front line.
This first slide, I want to talk about it real quick. And it goes back to the whole critical thinking and cognitive overload piece of it. I think this shows a great example of a nurse that's getting ready to do a blood sugar or getting ready to come in for patients getting ready to have surgery in OR, and they decided to drink some coffee this morning with sugar in it. And so the nurse, instead of her looking for a policy, what does it say if she doesn't know, she's a new nurse because she just got hired yesterday, or she came through COVID time and didn't get to do clinicals, whatever it may be. But she needs help. Instead of going through a policy and trying to find time or trying to find somebody who just started the day before them so they have one day more than they do, she can just ask from an AI platform, what is the policy, and then go ahead and take care of that. And so I use that example, which is a very simple example, but if I'm doing like a chest tube or something like that I haven't done, because guess what? The nurse who doesn't work that much, when I do work the floor, what do you think they do? They give me the horriblest patients, right? Or the highest acuity patients in a chest tube that I haven't seen in 2 years, right? So is the suction right? Is this and everything? But I have to actually go through the policy right now, look through everything to make sure, do I have everything by the bedside? This kind of tape, those kind of things. But if I could just ask those questions and it spit it out to me, that's the way AI can really help and support.
I'll just go here then.
Who knows what I did?
Okay. So with regard to asset visibility, again, we're talking about AI for the connected frontline. So we want to be able to track everything. Right? We want to be able to know everywhere, everything in a hospital. We want to know who's in our hospital as far as working. We also know where everything is. So we want to evolve how we're talking about asset visibility. And again, the base layer of asset visibility is really identity-enabled workflows. Are things labeled correctly? Are barcode, RFID, and tag? So we want to move from asset visibility to ambient intelligence. We want to thank you. We want to make sure that our organizations are more of a sensing organization so we can understand and see where things are at any given point in time. Also, Cassandra highlighted the ability of leveraging AI for the frontline workers to have different elements of feeding into systems that could pull and retrieve data at any given point in time at the point of care, at the edge of care. And then lastly, we're talking about intelligent automation. One of the things you will be hearing about or you will be seeing, we recently launched our customer first framework around orchestrated care. So if we're doing this right, if we're tagging things and we're sensing and we have a sensor organization, we're moving from a reactive organization to an organization that we can orchestrate care in a more effective way for patients and families.
Yeah. And what does that mean clinically? What does that mean if I know where stuff is? How would that help me? I mean, I gave you a couple examples, but what does it really do when it comes from an intelligent automation space? It does save time, but it does save frustration. I'm looking of why, again, I'm always going to go back to the priceless emotional state of mind. I know Heather told me last week they don't make no money, relationships, but why does it matter to everybody in here? If I know where something is, I can make a better decision. Do you understand that? I can make the right decision for that patient or for whatever situation I'm in. That's why it matters. That's why it matters. Okay? I understand we all got to pay bills. I get that. But the number one reason I work for Zebra and the number one reason I'm here is because I believe with everything that's in me that Zebra has the same moral values that I have, the same pillars. And I don't care what it looks like, but it's that patient. It's that frontline worker that's connected not just to each other, but also to the patient and to that patient's family, outside the four walls and everywhere else. And because of automatic intelligence, I can make better decisions. And it does not matter that I did not get to have that clinical experience when I was in nursing school. I have tools that can help me support where I'm lacking. Do you understand? That's why it matters. I can make a better decision.
I never thought about looking for stuff, and trying to find out how frustrating that is. Like, when I think about the tools I need to do my job, phone, my computer, printer, I spend no time looking. Let me tell you something. If I woke up tomorrow morning and couldn't find my computer, the amount of frustration that would cause me. So I never thought about it.
Yeah. I didn't even mention looking for people. That ain't came yet. I'll talk about that later. And in my keynote, I'm going to have I got some challenges for us to think about, because I wanted you all to come back still to me to understand there are so much work to do and so many other ways we can go from a clinical aspect as well.
And also from a regulatory aspect, right? So we have a lot of regulatory organizations that visit hospitals that have a certificate of participation for Medicare, right? So you have the Joint Commission you might have heard of. Medicare does their own, or DMV does their own. So one of the major things that people often get dinged on is their crash cards. My friends at Texas Children could probably commiserate with this. So how do I know that where's that atropine? And is it expired? Where is it in the hospital? So most hospitals, deploy tons of people to go look for these things, check these things daily. But if these things are tagged, logged correctly in a very scientific way, we would know at any given point in time where that medication is precisely. When is this useful life over? And we can avoid some of those penalties a lot of organizations get. So that's just more from a hospital operation standpoint. And then we also want to talk about the macro challenge, right? What are we dealing with from a macro issue? One of the major issues going on in healthcare is really around the employee pool, our labor shortage. We often talk about that. We've been talking about the nursing shortage since I was in nursing school, since I graduated nursing school. And honestly, people kind of been, oh, there's no shortage. And
how long have you been nurse so they can get that? How long it's been going on? Because this is new to them. It's not new to us.
So I've been in healthcare for over 2 decades. So that's been a continuous thing. But I think COVID really exacerbated a lot of different fissures that were existing that were kind of bubbling up. But COVID kind of pushed it to the forefront. So now you have a situation whereby a lot of clinicians are tasked with a lot of different things. They are overburdened. The amount of documentation that you have to do as a nurse, which is very different than what we see a lot of physicians do. Physicians are often leveraging a lot of dictation and narrative form. Nurses a lot more checking the boxes, and then you got to do that. And then also you have to think about the patient's room, family, make sure documentation is done, medications administered. So it's a lot more coordination around the patient's care. So how do we leverage AI to kind of alleviate that mental burden, that administrative burden that a lot of clinicians are burdened with?
Yeah. And from a clinical aspect, I just have a couple questions. Who in here is doing anything in their business with like hand hygiene? Nobody? Nobody? Like are you yeah, the hospital level, you're doing that. Okay, great. Right. And using those reports, yeah. And then have you tied that back to actual return on investment plus return on life?
They've done a little bit of studies around complexity and the reduction of some of the infections and stuff like that, but it's not kind of what ties into a yearly what we call it easy, which is kind of like the bonus incentive stuff.
Yeah.
So you have to get to a certain percentage that goes into years to get the goals for reporting levels.
You can track it down to the clinician level. Yeah. Me, because I'm sitting on this side, my head, the first thing I was saying, I was watching this use case, and one individual had like 56%. He never washed his hand. Never. Y'all know what I'm gonna do. I'm finna figure out. I wonder how many people, and again, I'm gonna take it back. Why does this matter to you? Because guess what? That person just went in your mama's room. And whatever he did in the patient room before, in the 25 patients room before, he done brought it to your mama. Every report, every statistics means something. And when we're trying to bring value, when you're trying to do a value op, and we're talking about dollars, you can take it further. I've never seen anybody do it, but I'm gonna take it further. Like, this is what makes sense to me. And you can go back and tie it to the infection rate and how much money that really costs you. We always looking at technology. Let's bring it, let's take it down to the person level. Okay? Go ahead.
I'm not gonna present with you again. Her energy is unmatched, but I'm gonna try to match her energy. And the second element that I want to kind of highlight is also around inventory and stockouts, right? So usually the normal flow, just kind of keep a high level of when a procedure is being done. You're scheduled for a procedure on, let's say, a Tuesday. I mean, Monday night, your surgical tech went and got a recipe card for the physician who's going to be doing your procedure. Oftentimes, a little bit to what Gary mentioned, sometimes there's something missing. And it's usually not until the patient is, on the table that is found. Fortunately, most of the time, it's before an incision is made at all. So that's a good thing, right? The bad thing is now that case is canceled because there's another case behind you. So with AI, with RFID, with the tracking abilities, we want to be able to understand where things are. And sometimes that's not a matter of actually in the four walls. That device, the implants, or that piece of equipment that's going to be installed could be on the way, could be in it could be in the salesperson's truck. So we also think about trunk stock. Where is it from the manufacturer standpoint? So we want to make sure that we have full chain of custody visibility on the critical assets that are going to the procedures that are happening in the four walls of the hospital.
Yeah, thank you. All I want to say with what I was talking about earlier is that's how I would want AI to tell me. I would want AI to tell me that if I was doing hand hygiene, I want me to tell me it would highlight this person and then show any infection rates to any rooms that he was in. That's how AI, that's the power of AI. I want to make sure I close that gap because I'd be talking sometime if y'all didn't notice and I'd be on tangents. But that is how AI from the reporting and analytics standpoint. So it's not just about the technology, but how can AI with your technology integration with the HRs or whatever's going on in the hospital and what the value that it can really bring.
And the last part about the managing inventory. So I've been a nurse manager on a different floor, and I can't eyeball my stockroom to know how much of one particular product is there, right? And if you worked on a nursing floor or if you worked in a hospital, invariably there's certain floors no one wants to go to. And why is that? They don't have beds, they don't have linens, they don't have suction, they don't have a lot of different things that are customarily known. So with the implementation of smart and effective use of AI, meaning that we're using it more purposefully, right? That any nurse manager, any leader can go to any floor and know where their inventory levels are. So they make sure that staff has the amount of equipment they need to render care. Now, take this out to more of a regional level. Because of my scope of my role is global, we have organizations in Europe that are looking at how do we leverage AI to know, hey, from a regional standpoint, how do we know what hospitals have what? So in case of an emergency, this hospital is out of stock of this particular medication. We know that that hospital, in an emergency case, cannot supply and provide care or provide support to other hospitals. So there's a lot of macro abilities and also regional abilities that we can have if we leverage a lot of the track and trace technology that we have with RFID and also implementing and feeding that information to various AI LLMs that we have at our disposal. And we talk about the frontline workers. So again, I kind of highlighted a little bit of the decision making. I think if anybody here who's been to HIMSS, you might have seen some examples of this, such as Elsevier or Micromedics, having that at the edge, having that on your device, your compute device being powerful enough and also to get the information, but also render it at the time needed. So we look at a lot of the things that we're working on in Zebra with our AI blueprints is how do we leverage AI on device? There's a mixed element of that, meaning that there's a privacy aspect of it because you're not pulling from the cloud. There's a latency that we also kind of overcome because it's coming from the device directly. So the information getting to the bedside at the edge very, very fast.
Yeah. The next in a couple slides, I don't know when we'll talk about some of the aspects like picture visions and everything. I was at sales kickoff. When did Tom speak? Last year? Must have been last year. Yeah, last year. And he was up there and he was showing how the person in the warehouse could pick something up, tell it where to go, and they know it was the wrong item and those kind of things. I was in my chair jumping, right? Because I was thinking, oh my God, this would be so great for healthcare. And the reason why I was thinking that is because I just told you if I need to walk in a room and a chest tube is in place, I would like to know quickly if it's already hooked up correctly and I got to do anything. So it'd be great if I could just take a picture, right? And say, yes, it's right, or no, it's not, those kind of things. In healthcare, we always have to think about one thing, life or death, right? So we got to make sure that when we implement AI and support like that, that we're not going to be doing anything. Well, who's going to own the liability? That's why hospitals are so leery with AI when it comes to clinical decision support and those types of things. And so we have to make sure that AI works. But I was excited because those are the things that keep me up at night, right? Those are the things that's gonna take me away from my patient is looking for those things that I'm not familiar with or I haven't done in a long time. So we'll get to some of the AI footprint here at Zebra that we're going, but my team lead brought something else to my attention. Imagine this. if a patient was on like a CPAP machine, right? And it's beeping. Does everybody here know what a CPAP machine is? Okay, they need it to help them breathe, right? Sometimes people go at night, they do it, right? But it's better for oxygenation, right? So a lot of times on the floor, it starts to beep, right? It beeps. I did not go to school for respiratory either. I didn't go for hieroglyphics 101, none of that, right? So if it starts beeping, I have to call somebody, right? But think about if I had a camera in the room that could actually tell me it's beeping and where the leak is. Do you understand what I'm saying? And already help me guide what my next step should be. Do I need to call a respiratory therapist or can I do this? That's the power of AI and using tools based on that. And when you think about RTLS, RFID tracking, what would be so great when I'm tracking people, it could tell me who's the nearest RT person. Do you understand what I'm saying? Let's connect all the dots. I won't leave you out, I promise you, but connecting all the dots and why it makes sense.
So again, moving from a reactive organization to a sensing organization. And one of the things that I want to make sure I bring to the fore with regards to how we talk about AI, we are very much a human in the loop organization, meaning that AI in this sense is more of an augmented intelligence. You don't want clinicians outsourcing their thinking to a machine. You want the person at the bedside really, really leveraging information and be able to dissect information and be able to anticipate what's needed for the patient care. So when we think about some of the things that we are looking from a cross vertical standpoint, how do we look at applying AI for digital twins? So that Cassandra mentioned various examples of a new nurse, right? So the best way to get comfortable doing something is if you've seen it before. So how do we leverage digital twins to kind of practice some of the things you might see in real life on the floor? How do we move more from a reactive organization to a sensing organization? So I know, hey, the temperature's off, or hey, that patient's breathing is a little bit more shallow than normal. So I know as a clinician what needs to be done. So these are the things that we think about when we think about artificial intelligence. But also, again, one of the things I want to mention is when we think about RFID, radio frequency ID as a data point. We want to make sure that that data is going to the right places so that we can then leverage it for other purposes that might be needed in an organization. Yesterday, we got a chance to talk about some of the BLE technology that we're developing. Like in the hospital, just again, from a general hospital operational standpoint, like where has the patient been discharged? Or have you had a family member that you went to the room and they weren't there? For people who don't have frequent experience with healthcare, that could be frightening. Did that person pass away? Where is that person? That person supposed to be back by a particular time. What if we have the ability, or we do have the ability, we just need to orchestrate it, whereby you can know exactly where that family member is. They're on their way, they're in this hallway, they're up the elevator coming back, or who was in the room, because we tagged everybody that we know, hey, your mom's doctor was here, her cardiologist was here, or her father's cardiologist was here at this particular time. And this is information because everything's been tracked. And also we took that information and put it in a digestible way for patients and families to experience. Want to just pause a little bit to get just some crowd reactions. Does that sound very farcical? That sounds something like you've seen or heard before? Again, the purpose of our particular part is really taking the art of the possible and making it the science of the actual. So we want to make sure that things that we're talking about are relevant, because sometimes you get we get tech out and geek out and talk about gigs and speeds and GPUs and all the different things, but we want to make sure that the information we're providing today is relevant to both your operations, because we have some healthcare providers here, we have med providers, we have different technology providers here. So we want to bring a confluence of everybody's collective skills and interests together to be able to make sure that we're providing value to the overall ecosystem.
This is already in practice, or is this still theory and moving towards this, I guess?
This is in practice. Okay. This is in practice. Again, so one of the beautiful things about Zebra that we have the opportunity for cross-vertical learning. So we can see things that are being done in manufacturing and then wonder from a use case standpoint, what's the applicability in a healthcare setting? Is it applicable? And who would be a partner that we could take to market to kind of see if this has utility?
Yeah. And I think all of this is here today and now. From a clinical standpoint in healthcare, is making it happen, and then having somebody's buy-in. Like if somebody was having a code and it's 4 or 5 of us walking into the room, it would be so nice just to, I walked in, I'm the doctor, and it automatically logged me into where I need to be. Those are the kind of things that make it powerful and can really help. It's automated, but helps with the whole, let me take care of the patient and I don't got, and get the tech conundrum out of my way. That makes sense.
So the operational digital twin, that whole bullet is fascinating to me. I have no idea what
So
like the sensor fabric is.
So the digital twin basically is pretty much kind of like using technology to kind of recreate an environment, recreate a system. So what we're seeing in some places we have seen this in is, for example, let's say a doctor in training who wants to do a surgical procedure. He'll put on some VR headsets and he will recreate what that surgery will look like. He can kind of sense that feeling. So it's like a virtual reality element of what that would be. Or you could do a mock-up of a floor, a mock-up of something going on that is virtual. It's not real, but you're visualizing it. So
yeah.
So it's almost like kind of getting mental reps, so to speak.
And also something that they may not have seen before or whatever. I was using the example of COPD, a patient who has COPD, they need oxygen, but the number one thing in pathophys is you can't over oxygenate them. I heard that, I don't know, 15,000 times when I was in nursing school, but it wasn't until I actually went into a room and the patient was like somnolent or whatever that I picked up that she was over oxygenated and had to go to the ICU. Now that I've experienced that, it's the first thing that's on my mind whenever I'm dealing with COPD, because it took me that experience to happen. I don't care how many times I saw it on a book. So being able to do that is what's going to help bring value and really help with, again, that critical thinking and things that you haven't experienced before or you want to brush up skills on.
You mentioned like mental reps in getting this. How long is that mental rep period before it starts to predict and be able to actually give you what's that learning period?
I don't have a good answer because I think it's dependent on the person. But again, this is more so the modeling, right? This is more so the tool. So we've seen X number of cases, and we can take, let's use Gemini Vertex, millions of cases, millions of studies of a particular procedure. This is how it should look. So with regard to the mental reps, I think that's really case dependent on the person. So I don't have a exact answer to that question. So.
And I think one of the biggest things in the healthcare, and we've got this one, because we have a EP who's pretty forward thinking and but it's actually getting someone to actually adopt technology, to get to proof of point that this is actually going to be valuable. My killer just graduated from this school as well, and so I know all the sins that she went through, but I can also see the benefit to having something that she can go into, like some glasses on. She doesn't have to go physically post somebody, practice and stuff, but do the thing that she wants to do. So but it's important to just get a little bit of to say, yeah, we're going to willingly take this into our organization and then go forward there. I think we're struggling to get our solution, which we'll talk about a little bit later, into other hospitals, into other people, and people say, yeah, there actually is a problem that we have, and be willing to say their problem. A lot of people don't say they have a problem, but it's like, well, they're bad.
Right.
And then you need to get to that solution.
I think the early adopters is a huge thing. Also, I think a lot of times from a technology standpoint, we underestimate the cost of that, the learning, and the learning curve, right? We're dealing with the multi-generational workforce. There are some people who naturally just get it. And then some people like my mom who retired from nursing and did not even touch an EMR or did just a bare minimum just to be able to keep her job at the time. You know what I'm saying? So because then she moved to an organization with the state, they didn't need the EMR. So she was back into her happy place. As opposed to myself, I grew up on EMRs. So actually I worked in an organization that went from paper, but I went to a school that was EMR centric. So I think we oftentimes underestimate that ability. And also there's a cost associated with that. How do you onboard people? Even user experience or UX. How does that go into that adoption of new technology? So again, going back to my early days, like we've been talking about RFID forever, right? And it's just now catching wind in healthcare, just now getting momentum. And this is something that we would think would be something that would be just, why haven't we been doing this? But to your point, Craig, like that whole adoption, and how do we get everybody on board to really understand the value of this of the technology we deploy?
Yeah, I was going to wait till the end of the presentation, but I'm going to pick back on. Since your experience is nursing and now you're a team, what are some of the roadblocks you see on
It's what he said. It's adoption. It's early. It's people not believing it's going to work. You have to. We go in. I tell our sellers all the time, our account managers, you have to whatever gets you in the door. You get in and you do a small use case and you go from there. I want to just give you one example at the hospital I work for in Kansas City. Y'all know that's where I'm from. Go Chiefs. But one thing we did is not-for-profit hospital, we write off anywhere up to $140 million, very forward thinking, because we need all the meaningful use dollars and everything. So we do a lot of technology. But one thing is we rent beds. We rent beds, right? So what do you think we did one day? We decided to track our freaking rented beds, or the beds that we had in the hospital, I mean. Just by doing that, we saved, I don't know, maybe $2 million. Why? Because we was just ordering beds, spending money, didn't know what the beds were based on our need for bariatric patients. Tracking is the best kept secret. People don't know what they don't know. That's the problem. They don't understand the value, but it's so much value just in hidden. But just because we simply tagged the 14 beds or whatever, how many beds we had in the hospital, and we rigged our system to, when we get to that point where it's tracking it and you got 13 beds. So when I place an order, okay, we know we need to get a rented bed. So guess what? We stopped renting stuff we didn't need, and we knew where our freaking beds were. Just that simple.
Also, and I also think from a technology standpoint, I don't think as an industry we've probably done a good job telling that ROI story. And I think oftentimes prior to the big beautiful bill being passed, we can rely on like volume to overcome a lot of the different costs that are associated with it. But now, when healthcare costs or margins are going from 7% to on average 2.7%, now those dollars matter a lot more. So I think those have been another thing that we haven't told the financial story for people to really buy in, because if we have a really, really robust orthopedic surgery service line that's bringing in most of the money for the hospital, all the things that are like not making money kind of glossed over. So how do we, now that things are being critical, now that the inpatient only procedures are coming off the list, if you are really into the healthcare policy stuff, where now those things that could only be done in the hospital could be done outside of the hospital. Now hospitals are competing with doctors that could do procedures at ambulatory surgery centers. Now those margins and that competition is a lot more tight. So now where are you going to get the cost savings from? So I think those are the stories that need to be talked about. I think everything Cassandra said is valuable. There's definitely a human element to what we're doing, but I think that also there's a level of fluency. We can talk about the human element, and we can talk about the business element of it as well.
Hey, my stuff always got dollars to it. I just do go a little further and talk about the return on life too. Another thing that's the biggest, I think, hurdle that we all have to deal with is the personas that we're talking to, and the personas inside the organization that don't talk to each other. And that's a huge problem. Clinical and IT, for some reason, is they on two different walls. They saying the same thing, but not saying the same thing. And so that is the one thing that is hardest. Before I came to Zebra, when I was going to take the CNIO job at the hospital I worked for, she was very aware of that. And that was the one thing she wanted me to fix, is IT and the clinical relationship. So I don't know how to fix that one. I really don't. I'm always doing these podcasts. I'm always talking about the value that informaticists bring, but we still have a long way to go. So I don't know. We got to keep pushing, right, on everything. But that's probably one of the biggest things, is everybody on the same page. Yep. It's hard.
Like from the CFO level, like you talked about, like losing beds and assets, and you got a guesstimate on the number or the value, like a CFO writes off at a medium-sized hospital. Like I've heard a number like 2 million. And then how do the ASCs now kind of flow into that? There's obviously a lot of law here, I don't know if we'll talk about that.
Yeah. So I used to actually work in finance, and the average hospital bed is about $30,000, like because they have all the bells and whistles and things of that nature. Now I would say oftentimes the bed is not like gone. Most of the time, it's somewhere in the hospital. But now we're looking for it, and we need it emergently. So then we end up ordering another one till we can find that one. Or the rare occasion is, hey, that patient has the ambulance came and picked the patient up to take them to long-term care, and they took the bed with them. So we have some of those situations take place. You mentioned something about ASCs as well.
Yeah, no, I mean, not just beds, but all the equipment in a hospital. How you know, right on. Yeah, most of the time, yeah, right.
Right.
We're working at a VA site now. We go do the tagging. We found 600 assets worth $1.5 million that were not in service, that were written off as lost or stolen or out of service or turned in just while we were doing our tagging. So right. I would assume that's probably, we find the same thing, right? In a hospital, if we really did a true wall to wall and walk through that.
Yeah, I mean, I think as I've seen it, there's definitely an element of backdoor things kind of going out the back door. I mean, medical equipment, medication, tools can have a street value. Sometimes they make it overseas, depending on the product. So I think there is a real dollar cost to that. I think with regard to some of the bigger items, I mean, it's kind of hard to kind of put a hospital bed in your pocket, but you invariably go to any major city and go to the local pawn shop. I bet you can see an IV pole there. You'll definitely see IV pole. You'll definitely see some consumer devices that are used in a hospital there, that need to be have a street value because there's a big home health business, and some of those people need those things at a home health setting that are more expensive if you buy some of that durable medical equipment from either a pharmacist or from a durable medical equipment site. So.
People just don't know what they don't know. I think that's the biggest thing. So they don't know what the potential value of what they're losing or not losing or available. I mean, the couple $1 million that we saved just because we were spending extra resources because we thought we didn't have beds available. And then if we had tagged that body that was in the morgue, it wouldn't have been missing for 2 weeks.
I guess each hospital a little bit, that ROI case, seems like obviously the CFO, but clinical quality, there's a lot, how do you get that?
I'm actually looking at Chad, because we just had an ROI calculator case. I don't not to put you on the spot, but I'm not sure if you want to speak to that about that ROI calculator with RFID.
It is in development.
Okay. Okay.
And Gary knows about the work that we're doing to have an ROI calculator that is backed by real research, the model is supported by, and from what I understand, it's been validated by certain customers. I don't know if Gary had I know with VA,
yeah, and I think we'll talk about the ROI, but you're right. You don't really, people don't know, and they're just like you're in the battle each day, right? You don't have you're going to take care of your patients, or you're going to look for this, and you just say, hey, it's a lost order.
Yeah. If you get somebody to do, I think one use case, prove the value, and then they'll probably expand. I mean, use cases was going to drive other healthcare organizations to grow or to take the challenge or jump in. And I think even at our hospital, we hadn't tracked anything, and that was our first thing. But that first piece is definitely allowing them to move into other areas.
I mean, we're finding like 500,000 to maybe $1.5 million of equipment that's been written off that we're just finding. The nurse will say, "Oh no, I got everything." We go, "Sorry, ma'am, we have to look in your drawer or your credenza," and we look in there, and there's 8 items. That have been stolen. Right.
Lost, misplaced,
yeah. But then there's 20% of the assets that are on the property book that you can't find, that they're saying they have, but are long gone.
Yep.
So there's you're finding some, but they need that clean data and a good, accurate baseline inventory you tag it with RFID, now you have that real-time visibility. There's a lot of cleaning up that needs to get done too.
Exactly.
I'll just add ROI, when I say it's been validated. To your point earlier, you mentioned how you can learn from retail, manufacturing, where some of this is already being deployed.
Yep.
You know, this fundamental issue of asset visibility or lack of visibility, it's been, I think some of the other industries have gone from I don't know what I don't know to I now know what I don't know.
Mm-hmm.
So those industries, we benefited from working with those industries with this ROI calculator, with the models that we've developed, and we're now able to apply it. And I think it's very applicable directly to healthcare. It's going to help open some eyes and help folks without having to go do a major study and hire, some firm to come and do a major study. We can provide them with some guides of this is likely what your ROI is. And really just help them get from that point of I don't know what I don't know to wow, this could be a real number.
Right. No, exactly. And I think another thing too, sometimes we just kind of drop technology at the foot of our end users and we don't really guide them through how to really implement it and what success looks like. So I think that's another element, that's another onus on us as technology partners to really walk that through and help them. For example, like who does this sit with? Is this a biomed related issue, or is it who's going to be responsible for doing all these different things? So how do we kind of create best case, best in class scenarios that can help them do that? And also, we also time to drop this technology and say, yeah, get it done now. This is a process. It's a journey. It might take a couple of years to kind of get to that full chain of custody. So, but where do we start? So we're going to probably likely hear from our friends at Texas Children where they started their journey, but also understand it is a journey. And they're as the years and months go on, they're kind of perfecting that journey. And so I just wanted to use this as an example again. Want to bring it back to what we're talking about with RFID and AI as far as an orchestration standpoint. So again, I talked about identity-enabled workflows. We're talking about starting at registration, where patients are, but also look about where staff is. Now, how do we, in AI, one thing I like about AI is really good at pattern recognition. How do we find data? How do we find trends? How do we take a lot of different inputs to kind of understand what's going to happen or predict or be ready for what potentially might happen? So I'll take my opportunity as I was a manager of a hospital. I had nursing operations and I had a clinical floor. So I had to do a lot of manual work to kind of think, okay, how do I understand this? Okay, there's a teacher strike coming down. It's raining, all these different things. Okay, it's probably going to be a lot of people in ED. My staff's probably going to call out. I had to do all that manual. What if I had all these things feeding into a tool, understanding my patient volume, type of patients that are in the hospital, where they are, the level of care, and that helps me be, as a leader, proactive on how I'm going to manage the day or manage the floor. Conversely, or on the other side of that, from a patient standpoint, patients are in the room. Where are they in the hospital? Or this patient has gone through this exit point, this exit point, this exit point. They haven't come back in 20 minutes, and we've had this happen thousands of times. Oh, that patient is discharged. Or we're going to automatically make that bed dirty in the bed board, and then EVS is going to know to go clean that room automatically. So now we're taking the human out the loop in the situation. Jeff, we talk about the zero human involved situation whereby we don't have to wait on the unit secretary to then go and click bed dirty. We are turning rooms faster. So patients from ED, patients who are in a PACU, patients who are direct admissions can get volume. So we have an accurate assessment of our velocity. What is our real length of stay at a hospital? Because a lot of times, patients are in the hospital longer than they need to be. Avoidable days is a huge cost for many hospitals around the country because certain things didn't happen. Now it's midnight. The patient has discharge orders, but who's sending the patient out to discharge them at midnight? They're going to wait till the following morning. Well, that's a day that the hospital is not going to be compensating. It was your fault that you didn't get these things ready, or that patient or that unit secretary didn't make that bed dirty. And she just forgot, and the next one forgot, and that room has been occupied, but that patient's been gone for 2 days, and your ED has been backed up. These are real life scenarios.
They don't have a unit secretary.
Or they have a unit secretary.
That's really reality if they don't have a unit secretary. And again, you're asking the nurse to take on these additional tasks, and that's what the reality is. And so being able to use like RFID and different things like that tracking that can make these unautomated or these unorchestrated care orchestrated care at that point.
So take away. I hope the takeaway from this is that individually, RFID individually is a powerful tool. Individually, AI is a powerful tool, but in combination, no, they're transformational, and they can be transformational again with the combination and strategic applications of both these tools together.
Okay.
Okay. So I think we're gonna let's kind of leave it right here with the global workforce, and then what Zebra is trying to create. Again, I kind of hinted at some of the technology that we're developing with our blueprints, where we're literally having AI being processed on device at the edge. A lot of hospitals and organizations across the country are looking at this as a way for saving on costs for cloud costs, because calling on the cloud every so often takes that's money, is real dollars that are being spent. Also, a lot of tokens that are being spent. So how do we leverage the device and the power of the device to also do this, to retrieve information at the edge, but also understand within the context of an RFID standpoint where I am in proximity and orchestration to the care I'm tasked to deliver.
And Cassandra mentioned about the security, the risk, we go to HIMSS and you see, Amazon and Microsoft. I mean, everyone's talking AI and cloud. You got robots with cameras that are going into rooms and delivering medications. I mean, where are we at? Are we, are the Epics and Cerner, are they incorporating like AI module? I mean, I know it seems I'm a little concerned about an AI bot recommending my treatment or this too,
So it's interesting. I was literally on a webinar, actually, recently, and where we have physicians on the call talking about AI and people thinking about like what's AI's role in healthcare. And the reality of the matter is, AI, ChatGPT, they don't have licenses. So ultimately, the decision, whatever thing that product puts out, is on a human who has to make the decision. AI can only retrieve, and I have to make that decision as a clinician or as a leader or whoever I'm charged with to either accept or reject what is given me. So ultimately, the best use of AI is augmentative to leverage and help as opposed to do. And I think that's actually what I talk to my son about all the time, because he got in trouble for using AI and try to submit a paper because he didn't do it on time. But again, I told him that you have to have baseline intelligence to use artificial intelligence. So if you don't have that down, then you're in a world of trouble. So I don't think you should worry about that. At least not from what I'm seeing yet, but then I could be wrong. The way this technology is evolving very fast. But again, the magic of AI is to be additive, not to be replicating the decision making of a clinician.
Yeah, and if you are at a hospital that's doing that, check out. Check out.
We can.
Yeah.
Yeah. Exactly.
Yeah.
I mean, and just from a low risk standpoint, they're using a lot of AI and a lot of insurance and looking from pre-auth and insurance claims. And we're seeing a lot more insurance claims being challenged because they didn't have a lot of the critical decision making that's needed to really either accept or deny a claim. So again, it's not a panacea; it's a tool. And again, that tool does not have a license. That tool does not take a state board, things of that nature. So ultimately, the responsibility of your care is really the person who has a license to render set of care.
Yeah.
Mike has some headache. This he types into AI. Oh, I've got this disease. You got to be careful.
Yeah, I mean, but people have been doing that. People have been using WebMD for a long time, and coming
Google.
to the physician's office with a spreadsheet like, "Hey, I have all these different symptoms." Again, it's incumbent upon the physician to really run those tests. But I mean, again, I'm not saying it to discount AI totally. It is a powerful, impactful tool, but it has to be guided.
Yeah, I was at AONL last year, and I was at this AI presentation, and they were using it for under triaging and over triaging. Does anybody know what that mean when I say that? Okay, so you go into the ED, and I'm gonna use Heather because I know her name. She goes into the ED and she says, "I have a chest pain." That should get her back quickly, right? But let's just say I'm at the front and I put her as a 2, or the opposite.
Yeah, 2 is the lower the number, the more severe the
Right.
patient.
So I put her as a 4, right? So I just under triaged her. They were using AI to prevent under triaging and over triaging, which is great, because if I under triage, like what I just did was put her at risk. Do you understand what I'm saying? So they're using AI to help reduce the under triaging, which will keep the patient safer, but also over triaging, what would save money and resources, because I am using resources on you, and you just came in here because you stumped your toe bothering me. You see what I'm saying? And but so that's over, and they saw in just a short period of time a significant. But what I did like about that AI is every time they didn't agree with the recommendation from AI, they would disagree and then tell them why. So they were making the AI smarter. So that's a perfect example of they're giving them information, and then they're making the best decision as the clinician of what they should be doing.
Kind of where, like, you're not taking the person out of the decision, but are you tracking the success rate that's coming back based on binary?
Yep. Mm-hmm. Yeah, they did. It was pretty good. That was one of the ways I had saw AI used in a clinical setting, because the other stuff, the scheduling, using the reports and that kind of stuff, I've seen that. We've been doing that for years, but I was trying to see a clinical use case of what we were really doing, other than me calling you up, talking about how you doing today, what's your problem, and talking to you, because we can do that too. So. But yeah, that was a great use case. The return on value was great, and they only had done it for a couple of months and already had seen an amazing improvement. And the piece of under triaging had improved is the best, because again, even though they can see the return on investment, that return on life is very important.
Like imaging, like analyzing radiology.
Yeah, radiology imaging is one of the biggest use cases, but again, they still need a radiologist to
confirm it. Yeah.
Yep.
So I attended a conference at Mayo where a radiologist was talking about how they prioritize the severity of the cases, and you get the more severe cases in front of the radiologist first. So it's more efficient.
Exactly. Again, it's at the end of the day, AI is pretty much math. It's taking math, taking patterns, and it's ingesting it, and it's putting out an output. So it's taking words and things of that nature. But again, it's only as good as the inputs. So if your data capture ability or your other inputs are faulty, you're going to get, just like when you prompt Chat GPT wrong, you're going to get wrong outputs. No differently than if we don't have the right location on a patient and we put that in there, it's going to give us the wrong output. So essentially, that's how we need to look at how we leverage AI. And again, how do we calibrate it to what we're trying to accomplish?
Yeah. And if I was using AI, like to help the new nurse of recommend who they should see first, if there's critical information that has been put in by the clinician, which takes you back to the clinical mobility piece of it, got to start there, is that it could still recommend them wrong, even though, because they can only recommend them based on the information that they have. But if I didn't put in a critical result or whatever it is, it's not going to recommend. So
it seems like the healthcare is still at some space like telemetry now at each deal. For tracking patients, sensors, getting all that out of it.
It's really the best case that I challenge Phillips and people to go into, just because of a situation that happened where I've talked about this before, but I'm gonna ask you guys again. In hospitals, when you hear asystole, everybody know what asystole is? Heart stops. That's what it is. In the hospital, like on TV, they show it all the time, right? And they show you shocking people. That don't happen. That's not real. In the hospitals, when you hear asystole being called, or when you see it going off on a monitor, probably 98% of the time is not true. It's not. You know why? Because leads are off, batteries or whatever. So if you have somebody watching that, it's just like the boy who called wolf. I done had that 11 times. I'm gonna just cancel it, right? And so, but the reality is there is gonna be a time that is for real. And somebody's they're gonna ignore it. And then the patient's in trouble, whatever. Experience that too. But when I went back to look at the situation, this is where AI would have helped. As a nurse, when I pulled all the reports, because I'm the IT nurse, don't forget that I'm the IT nurse, and I looked at everything, I could see when I had all the data together, that's where the patient got in trouble. Because another fact, or what you can look at, when somebody goes down, decompensate, something was happening 24 hours prior. You can write that down almost as a fact. And so basically, when I went back to look at the report, me and my coworker, I was like, boom, we both were saying, boom, boom, there it is. But all that information. So I was with Brian. Brian had a piece of the information. Heather had a piece of information. Tamara had a piece of information as the physician, as the nurse, but all at given times. And I simply said, at no time we would have figured it out. But AI would have played a great role if they would have pulled that data and said, this happened. It went from a 30-point switch because it still was normal, but a 30-point switch for me as a clinician, no, that's not good because that's a 30-point switch, even though it was still normal. AI would have helped. When I looked at that, we could not have predicted that because all the information was given at different times. AI would have been a brilliant. And I don't know if Philip's thinking about that, but if they call me, I'll tell them.
Oh, is it time?
Please.
Okay. So, new construction, hospital expansion projects, looking at renovating departments, sterile processing, right?
Yep.
How to be more efficient. You guys utilizing AI to optimize workflows, and then, for instance, that health system that you also work for, are you using that in your going back to the designer, the architect on telling that how you want it designed, or are you allowing them to kind of share this is the best way to design the workflow, how the sterile cores are set up?
Right. So we don't necessarily do more of the building. I think those new hospitals, there's about 200 new hospitals being built or renovated a year in the US, just because the average age of plan is over 50. A lot of these hospitals are very old. I think the data that we leverage, or what we look at, is how do we create new hospitals that are going to last a lot longer, composable, that can adapt with the technology as it evolves. You have a proliferation of data centers. Some hospitals are large enough where they're actually building their own data centers, but with regard to design, we're not there at the design level, far as what hospitals are building or how they're thinking about it. But with AI and with tracking and tracing, that we can see, hey, we have all these readers within your hospital, and this is the average number of steps a nurse is taking to render care, and this is how ideally we want them to be able to operate in the course of a day. That information is being utilized. So I have a friend who actually works for Canon Design who actually does develop this, and he does tag a nurse before they go and design things. And they do leverage that information to say, hey, this is what we want optimally. We don't want your nurses. Some nurses on average can walk up to 4 miles in a day for a 12-hour shift. That's a lot. I mean, I think 10,000 steps thereabouts. But that's them doing work. And also 10,000 steps while pushing a cart in some cases, or doing other things. So you want to make sure that they're taking the necessary amount of steps, but the minimal amount to be able to render care. So that's an example of how that leveraging AI, leveraging tracking and tracing of RFID technology can go into the composability of rendering care.
That's it. I don't have anything else to say. Any other questions? Thank you so much. Thank you, Pippin. Appreciate it.
We've been partners with Zebra for roughly 15 years. So we have hundreds of thousands of devices that are under our platform. And that's really what we have built, is a platform as the MSP. So we sit at the heart of a lot of conversations when we're in the boardroom with not only the CNIOs, the CIOs, the CTOs, the clinicians themselves, the charge nurses. And on the platform that we have built, it's listening to them and doing basically it's the sales 80-20. It's 80% of the customers doing the talking, 20% of where we do the solution solving. The platform that we have built we can only do so much. We are very unique in what we do in the healthcare space. We can't be everything to everyone. So that's why in the ecosystem of partners, we can solve for just about any situation that a institution may have. For example, when we start working from the users backwards as a part of our methodology on our Edge platform, we start to ask, what is your mobility strategy, your clinical mobility strategy, or your clinical communications strategy? And a lot of institutions, they just don't know because there are so many options. They don't know what to do. They're lost in the woods. And that's where SMG3, with the strength of our partnership and our ecosystem, with Zebra, working day in and day out. Also, our partners, like, for example, you heard Cassandra earlier. She talks about staff duress. When we design all of our solutions, if staff duress is a concern, and every day there's things going on where hear about a clinician being attacked or not able to control someone they thought they were on a certain medication, the next clinical nurse comes in and it's wrong, and that person is off the hook. And what I mean by that is they're violent. So what we can do is take 911 cellular, for example, and on the HC50, which is one of the flagship Zebra devices, there's a duress button. We can just press it and it'll alert either the local security team. Yeah. So this is the flagship device. I'll pass it around and, I'll get to the art of the possible, as far as what we can do. But for example, when it comes to Tiger, Epic, Rover, if they want these devices to be incorporated with having Teams and Outlook, we'll work with their IT staff. We'll get all of those feature sets in here. There's also outcomes where you hear about it takes 17 minutes for employees, clinicians to log into their device. And by that time, they're losing quality patient care because they're waiting on the device. So really, as the integrator, we are sitting at the heart of all the problems, and then we go to work to design. So for example, are there, mobile device management, life cycle management, all the applications, the interoperability. From the PBX side, do they have a Cisco, ShoreTel, Mitel system? Are they doing unified communications as a service? Everyone's probably heard of 8x8, Ring Central, NICE. Those are some of the predominant players in the healthcare space on the communication SIP trunking, side. We take all of that, we customize it, and we deploy. A lot of our solutions, though, and that's just one side. So in that end-to-end customer journey everyone's heard about, what we take is the OEM, Zebra. We believe in them. They are the only partner that we have built into our ecosystem for healthcare. We are an Android shop only. The I solution, if you catch my drift, that's not even part of it. Because that is not a clinical mobility strategy. There you go, Cassandra. Reason being is we've built the platform and we've been in the trenches. A lot of the Zebra folks here, whether it's Cassandra, Xavier, Heather, where did Heather go? Heather, we're in the boardrooms. And as everyone knows, these solutions are not just one and done. Every customer is an individual case basis. We may have some healthcare institutions, they may use 2 devices. We may have applications. We may have others that use up to 10, 11, 12, because what they're looking for is time management, time savings, and one device to really support their workflows. It's a proven fact that our solutions lead to 67% greater efficiencies and time saving. And that's from the platform that we have built when we take a look at all of their processes, their procedures, their applications, and we customize and design these devices as well as the other array of services that we have built into our platform, built on the strength of partnerships. With ID integration, and I'll segue over to Troy here in a second, RFID, it's huge, it's growing. On the MSP side, we pull in all the KPIs, all the analytics, all the data. So for example, if devices go lossing, In partnering with Zebra and their device guardian, we have deployed recently into a healthcare institution by the name of MedStar out east in Baltimore. Their run rate used to be about $1.6 million per year in replacement lost devices. Now that run rate is less than 5% of that number. Reason being is we continue to evolve and grow with our partners. We can bring all that in. We give them one single pane of glass, not only to order new devices, inventory, tracking, management, the KPIs, the analytics, utilization. We bring all of that in, even if getting down into the weeds. If you want to know your users and their utilization of said apps, whether it's Epic, Cerner, whatever, are they using it 30% of their work shift? Are they using it 90%? So that way you have the intel, you have the analytics to really have full control. And that's where we sit as the integrator. We're almost the glue that brings the best parts of all the worlds together. And then you talk about lifecycle management, for example, whether it's this HC50, Susie or Johnny broke it. They go into our Edge platform. They open up a trouble ticket. We will take out a device, flash configure, QC, ship overnight. That's what we do. And now with our new partnership with RFID, that just expands our Edge platform because we are always continuing. It's our job as the integrator to continue to evolve and grow the platform to make sure that we're focused on the users, their experience, and outcomes and solutions. So with ID integration, this is where we now are covering that gap of the RFID built on the Zebra platform, but then partnering together.
Yeah, and one of the things I'd like to say too is with our partnership, it's not only just SMG3 and ID integration that make a full solution. And unfortunately, one of the partners that was supposed to be in my place today is from Sonitor. And so they offer the platform that gives the hospitals one dashboard. And so you've got multiple different technologies that can get pulled into this. And so just to, that's not where I want to go. There we go. And so it's the different technologies. There's different use cases for different technology. There is not one technology that can solve all issues. For instance, you have specimen tracking. You're not going to put an active tag on a specimen, but we can do it with passive RFID now with the way that the market has gone and what Zebra has done with the tags and the readers. We can put readers in ceilings with antennas and still be able to read that 8 to 10 feet down to get to that individual specimen to be able to watch that chain of custody as it leaves the OR and makes it its way to pathology. So again, but we've talked about earlier is the entire Zebra ecosystem. We are part of that ecosystem and everybody here. So.
Yeah, and the nice thing is with the data that we can actually pull from ID integration and Sonitor. So now once again, everyone talks about that single pane of glass, that one throat to choke. This really gives all the KPIs, the analytics, the specimen, the cart, the bed. There was a story that was shared earlier that I won't reveal, but it was fairly morbid, but something went lost. And they didn't know where to find it. And when you hear stories like this, as far as the pain points and just all of the day-to-day issues or, speed bumps that get in the way of clinicians providing and giving excellent care and just having time, this is where we start to talk about the art of the possible. Taking the time to step back and putting on the consultative hat, and everyone claims to do it. With the Zebra folks here, SMG3 does do that. We've been doing it for years and years and years. So the platform that we have created really says, what are your pain points? Are you using that I product? And are you trying to manage it with the other I MDM product line? And if the answer is yes, then the first thing we say is, all right, let's start working backwards. Let's unravel where you've gotten, tripped up. And once you start to show customers or institutions what all these different solutions can do for you on unified devices, and they're not carrying 3, 4 devices, as you heard Cassandra say a little bit earlier. You're now, it's all about speed to market, patient care, and outcomes. And that's really what we do with our array of partners. And now that we can bring in ID integration from the RFID perspective, now you're talking about additional speeds and feeds for the clinicians to give better outcomes and solutions. Sort of a funny note, now that we are partnering together, we put our 2 marketing teams together. They came out with a 40-slide PowerPoint deck, and Troy and I are like, no, we don't need that. No. So that's why, if you want to do a little show and tell later, I can show some stuff off a little bit later. But really, that's where, in partnering with Zebra and Keith Larkin and his team, as far as the sales engineering, the product team here at Zebra, which is always fantastic, this is where we start to show the art of the possible and the solutions. And we built a platform where we can design, deploy, maintain, but then some of the key things are it's sustainable. So that way, every 36 months, every 60 months, whenever they're looking to do that refresh, it's a platform that they're not lost in the woods. We're unraveling it. We're basically paving the way together in the strength of our partnerships so that they can do what they do best. They can go take care of patients. They're worried about patient satisfaction, patient scoring. Where's that specimen? Where are my devices? And now that we talk about AI as well, there are institutions out there like AVA. I don't know, how many have heard of AVA here in the healthcare space? A few. So imagine a world where the HC50 or said Zebra clinical device is now paired with what's called a WS101. It's a wearable badge. So imagine a world where I mentioned duress earlier. Imagine, Brian, that you are a clinician and all of a sudden you've got an out of control patient, pineapple. What does that mean? That means that through 911 cellular and the integration into the HC50 and the WS101, that's a code word to go directly to your 911 health center. So those are the things that we can do. Or in the world of AVA, for example, coming back to that, imagine a world where you press the WS101. And this is still under R&D with SMG3, but in the very near future, imagine a world of tell me what my client list is today. And it'll say patient XYZ in the NICU, patient ABC in PACU. When was the last time they were charted? It was yesterday at the right clock. So those are the things that we are working on with the strength of our partners in our ecosystem, not only from the AI perspective, but then also from the MDM perspective, where if Troy wanted to know how many devices do I have in the NICU, and when was the last time they actually reported it in? Within nanoseconds, it can run a report giving you complete and total visibility, whether it's institution-wide or if it is just a single department. So really what we do is we provide the satisfaction where a lot of users are dissatisfied in our workflows and in our design for optimal outcomes.
So with that, let me ask a question then. So if I'm a hospital now that doesn't offer anything, and so you've got to go get to the PBX and overhead and do that, how would I get started? As far as you've got different applications, we have different use cases, but how would a hospital go about entering into a pilot with SMG3?
Yeah, great question. So once we have done the initial concept, the conceptual process, we go through what's called a first look demo. It's a POC. What we've coined it is, our first look demo is basically a 75% build where we will take these devices, we'll configure them, we'll give them in the user's hands. For example, you badge in. We're partnered with Imprivata. It was that quick. Just a badge in, we lock it down, we customize it, we add the apps, and we will deploy it. I can pass this around, Brian, if you want to, please. It's just a small subset, but these are the customizations that we do. And then when we deploy, typically it's about 10 to 15 devices. We will choose the institution will choose a division for us to go ahead and deploy these to. They'll kick the tires. Like I said, it's not full build, but they'll start to see, oh, okay, this is pretty cool. We'll find where are the issues, what else do they want to add, maybe remove. So that's the part of the first look demo. And we've had institutions hang on to these first look demos for, it could be as little as 30 days, it could be up to 6 to 9 months. With some of our larger institutions, like Memorial down in South Florida, they held on to our devices actually for 12 months while they were going through all of their approval process, giving it into the clinician's hands to say, this is what the state of the future is. It's a platform that has been designed and we can modify and customize it. So that's really the engagement process. After we go into the boardroom, we do the whiteboarding. And what we try to do is we make sure that we're talking to every single division, all the way from the clinicians to IT to tell us about your network, your routers, your switches, are you Cat 6A, your IDF, do you have fiber runs? We go through, it's called a golden image process. And so that's how we really, what channels do you want open? What channels do you want disabled? For example, in the NICU, what are babies supposed to do? Anyone? Sleep. We were a flagship developer with the University of Maryland Medical Systems, proven case study. They just had alarms going off. Babies weren't doing very well. And SMG3 went in about 6 years ago. And we developed a process on our platform where we lock down the devices. Instead of 100% screen brightness, we'll lock it down to 30%. Volume, disable. It's vibrate only. And then there were a couple other features that we just completely eliminated. That way, the babies are resting better. They're getting that needed, rest for whatever situation they're in or have. It's led to 60% greater outcomes. And so now, University of Maryland Medical Systems, they are walking individuals through, not all day long, but as a case study of how a NICU should be run. It was born out of us listening, going to work, designing, not only at the device level, the MDM level, and then deploying, and then it's the tweaking as needed. So that's just one example of the platform and the process that we go through to do not only the engagement, but then also the deployment. And now a lot of times people ask, how do you deploy? Well, it depends on the institution. Some people want to just solve their greatest headache, and I'll make this up. Maybe it's 4 West, maybe it's a NICU, maybe it's ER, whatever the case may be. But typically we go into it's the domino effect, right? We will design, deploy, choose a division, and then we will go to we will go to deploy and test for 2-3 weeks. What's the good? What are the challenges? What do we need to roll back? And a lot of times, because not only are we the OEM provider, also the MDM, we can deploy and roll back either real time or in a change management window. Most institutions like to do changes at 11 at night to 4 in the morning, somewhere in there, during less productive timeframes. So that's really the engagement process. We'll do a design, we'll do a rollout of one division, and then once that one division is successful and there's user adoption. And that's one key thing that I think Troy can also speak to is once you have user adoption and your clinicians are all in, then the rest starts to fall into place. And that's, a lot of times where things get hung up with other solution sets that aren't fully baked. We're not here to sell you widgets. We're all about outcomes and experience.
Yeah. One thing I'll say is we're there to solve particular problems. Again, my comment earlier that you're not going to have one technology that can solve everything. we really want to come and understand each individual business problem. And then, going back to this map here, it can show you passive technology can do a lot of it, but some facilities already have some technology already implanted. And so one of the things that we don't want to have to do is come in and rip and replace. The hospital doesn't want to do that. We don't want to do it. Again, that's why we partnered up with Sonator to offer that single pane of glass. So, we go, when they need that really defined precision, we can use ultrasound. So we've got the ultrasound tagging that can give you centimeters on where either that person, that patient is, clinician is. And if you need asset tracking, maybe we can use passive technology there. And then that segues really well into the specimen tracking. If you're doing specimen tracking, where is that captured at? That's captured in procedure rooms, ORs, which are the same locations where trays can be kept also, or, as they're utilized. And so the other portion then on specimens is you go to pathology. And so we put our readers there. So once they reach that destination, then we know that. And then same thing with the trays. All we do is have to go to SPD, and then we put reader and antennas on both sides of autoclave. And now we can capture cycles that trays are going through. And so again, it's really about understanding the business problems and coming up with the best solutions. And the different technologies are out there now that are performing extremely well. So,
yeah. Oh, and let me show you with the badge, with the Imprivata, and this is huge in the clinical space. If you just badge in, that's how quick it is. So I'll keep that with you guys if you want to pass it around. Yeah. So sorry, I should have held. Cool tech. So really so what are some questions? What are, as far as like the integrator, where, like I said, we sit at the heart of it all day long, Heather.
Customers with migration, they're an iOS shop. They are moving to a solution.
Yep.
How do you cope with that with the app?
So good question. So we are, just to be very clear, we are not an app creator or developer. Whatever is in their workflows, whether they're legacy Epic, Cerner, Mobile Heartbeat, Tiger, Rover, Haiku, I could go on and on. We will take those apps, we will load them, we will do some light configuration, and then the rest is up to them once they log in and get everything going. So but yeah, just to be very clear, we can't be everything to everyone. So built on the strength of partnerships, that's where, some of the solution sets I've talked about, that's where we bring in, the other ISVs, and we will do configuration, load it, test it, out of the box. Susie or Johnny fires it up, it's ready to go. So, and then when it comes to, and just to be about SMG3, we are our CRM, we are a Salesforce development shop. We have 8 programmers on staff. We are all about customization and modification for institutions. Whatever KPI or analytic we can pull from our ISV partners, like ID integration, or if I pivot over to SODI, Workspace ONE, everyone's heard of, or most people probably heard of 42 Gears in this space. We can pull all of that. There are baseline metrics. If they want to go wider and deeper, then we can do, I mentioned app, as far as utilization, as far as battery lifecycle management with the HC50s right here. These are the pop out, pop in, out of the box. It's 100%. After 24 months and you're utilizing it, it might be at 65 or 70%. So now you've got the KPIs and the analytics and the intel say, our battery management practice, we need to get fresh batteries so that these things are lasting longer and they're staying in production longer for better outcomes for client satisfaction. So, Heather, does that answer your question? Any other questions?
Good. Yeah. All right, thank you.
Yeah, so, all right, thank you.
Okay, one of the things that we want to talk about is is ROI in a 90-day plan. ROI is really a big piece of that. One of the things that we have discovered just recently with Gary has done a very large ROI calculation for VA and gave us a lot of information, provided the VA. In fact, you want to go ahead and discuss that and kind of walk through that?
Sure. Now, VA is a little bit probably different than some of our community and public hospitals because since they're government based, they're mandated by law to have to do 100% wall-to-wall inventory. It's a directive that, because we're all taxpayers and we spend a lot of money, but I think some of the use cases that we'll see, I mean, we're hearing that obviously from Cassandra and various people today. We know in hospitals across the board, there's a lot of write-off of assets. There's a lot of, missing equipment. And I know hospitals, have to do inventories for banks, for checking your balance sheet and, for financing and things like that. So within the, the VA, they have, they have to report, and it's the same on DOD and DHA hospitals too. They have if they have a piece of missing equipment, they have to do what they call a report of survey. So it's a formal document. But before they get to that, they're typically spending hours walking around looking for misplaced equipment. And during their inventory, they're having to look for this. So they have to do these report of surveys, and they have to report to the VA and basically to Congress. And I would say on average across VA, there's probably $50 million of these reports of survey. I think that's probably on the light side, but there's 172 medical centers. But just as we looked at that, but then on average, they estimate there's about 35 hours per report of survey of labor just to manage that. It's kind of looking for the lost part. They have to, I don't know, at a hospital, if you guys lose a big piece of equipment, I'm sure there's people that are looking for it, that before you write it off, there might be an investigation. I know we saw one VA, they had two, they said the value of it was like $500,000 for a mobile piece of imaging equipment that went across a sky bridge from the VA to the to the college and went out the back door through the receiving 2 times. They finally found him, but they had to buy 2 extra. That was $1 million. I think they might have found one, but I think Cassandra mentioned about, we do see parts going out the back door during COVID. I mean, how dumb was this? If you're, that was at the Seattle VA. They had one of the techs trying to sell ventilators on eBay during COVID, right? I mean, he's in federal prison, right? So not a good move to do that. But just, on an average with that 35 hours, they had like 18,000 reports of surveys or items that are part of that list. There was over 600,000 man hours of labor just looking for and processing lost assets. And it's 250 FTEs just to process that. So I don't know if it was Cassandra, that until there's some visibility on it, people don't really know, I think, the problem. We're at a large VA facility right now, and we actually have a team of people that, as part of our service, we go and actually room to room. We essentially do a full wall-to-wall room inventory. We get a list of all the data, but we go and clean up that data. I mean, we see refrigerators that say server, I mean, the tags are very bad. The data is bad. So we'll go and clean that up. But as we go room to room, so far in just one site, we found over 600 pieces of equipment that were listed as and not in service. It's close to just the valuation we got from the database is over $1.5 million.
And not in service representing stolen.
Lost or stolen, out of service. They do have parts, this bucket called turned in too, that could be obsolete. But the scary part too is there's equipment throughout the hospital that, this out of service category could be equipment that needs to be calibrated or maintained and go to biomed, before it's used on a patient. So, Eric.
You're not inventory, right? But
No.
Are you inventorying time in stock?
No, in this case, it's just non-expendable equipment. So it's not supplies.
Dollar threshold to it too.
Okay. Yeah, and so it's property book type equipment, assets. Yeah, and equipment. And I think the labor savings, but I think like Cassandra was saying, everybody knows, we're trying to figure out how to put a value on, and I don't know if it was Cassandra or it's one of the slides that was interesting that it costs $1,000 to $10,000 to cancel a procedure. But this is happening all the time. I mean, you can't find a piece of equipment. I mean, I'd rather have the canceled than have the patient open and be in the middle of a surgery and then not be able to find items and equipment. So I think that's a huge area of, when we're building out return on investment, that labor cost. And I know everybody's got staff shortages, the distress, the getting back that wasted labor and time that the RFID solution really helps. I might mention we've done a lot of work with the FDA, the Drug Research and Testing Facility in Maryland and St. Louis. And their ROI, is that their research scientists basically waste 2 to 4 hours per week looking for solvents, chemicals, equipment that's used in their drug research and their experiments. So, I should put my, calcium carbonate back in the storage room and, but it's on my desk, right? So they're tagging up in Maryland to like 31,000 items in their, of all their chemical solvents, tooling. And then they have this electronic lab notebook that documents the experiments. And now they get a bill of material out of that for each experiment. Now with passive RFID, and we have full room level, lab level tracking. We have RFID antennas on each side of the door, so you know if it's coming in or out. And each antenna has a unique location ID. So now when they get that bill of material in real time, they know that that's in lab 8, storage room 7. So now the research scientists can go pick up all their parts and know exactly what room to look in. And these are pretty high-priced people. So 2 hours a week, 100 hours a year. They have 52 research scientists in one of the labs. So that's over 5,000, 5,200 hours they're estimating. It's over 2.5 FTEs, and maybe they're 250,000 a year. So the return on investment was less than a year. And somebody mentioned too about, the overstockage and overbuying, where they need all these chemicals. So everyone would just had their own private, Amazon where, they'd buy their own chemicals, so there was so much excess inventory. So that was another area of, for return. That was an easy return on investment.
So, and just going through this we were talking about specimens. As I'm traveling through the country and visiting different hospitals and walking through, as Alan kind of alluded to, that was me. I had walked into a facility. We were actually there for an asset inventory, IT asset inventory, and I had asked for a tour of the entire facility to do a better site survey that way and be able to talk to personnel. As again, I want to get a better understanding of the business problem. But in doing so, I happened to run into an L&D manager. And so I started talking to her about specimen tracking. And that's when she told me the story about something that they had lost. They didn't know if, I don't want to go into too many details, but L&D, you can imagine. So anyway, we've won another large IDN specimen tracking. And what we found out, what happened there, because when we got the original RFP, it was just asset tracking. It was going back to IT assets type of thing. And then at the 11th hour, all of a sudden they say, hey, can you also do specimen tracking? And yeah, we can do specimen tracking. And never could find out what was going on and what happened at the 11th hour to go ahead and open up the budget to bring in specimen tracking. And I happened to be up there doing a site survey with one of our engineers, started asking questions, and sure enough, they had lost a spleen sample. And, it's things like that. Because right now what we're finding out is about 1% of all specimens are going missing. Now, in most cases, it's a recoverable specimen. So it's doing another blood draw, urine sample, not a big issue. It can be an uncomfortable conversation when you've got to go draw again, but that's about it. It's the irrecoverable. And again, I've heard some horrific stories other than that one on what is taking place, and what that's adding, of course, is cost, risk, litigation. And so that's where we're seeing a big opportunity within hospitals. It's also a tough conversation to have with hospitals, because when you go there, there's a lot of NDAs in place and things like that. And really, they don't want to admit that they have that problem. But what we find is maybe after we leave, or I get pulled aside as we're walking out the door, hey, can you tell us more about what you can do for specimens? So that's what we're putting a lot of our focus now on this. We've got another facility that we're working with that the way that they handle the specimens, and the way that we want to do it is readers and ceilings and antennas being able to put, but the way that they are collecting the specimens, they'll get tipped over. And again, as it's been mentioned, when RFID doesn't play well with metal and liquid, but as long as we know it, we can mitigate all of this. And so we have actually done that, and we've created a new device. It's an all-in-one device that we've dropped 3 RFID tags within a liquid and reading all 3 tags right away, so with no issue. So again, it's one of the things that we want to do is understand all these business problems that hospitals are having and being able to come up with the right solution. So again, as Gary mentioned, with asset tracking, which is what we're doing in the VA, then we also have the tray tracking. That is a big issue with med device. I've worked with med device for a number of years, and actually our work with Tamara and in the Zebra team, they started coming to me and say, hey, what can we do at the hospital level for tracking these surgical trays? And that's another aspect with this new device that we've created that's giving us that availability of reads in these procedure rooms, these ORs. And again, then we go to SPD. And because one of the things that med device is also wanting, especially when you have park trays in these facilities, is you want to get cycles. And so all we do is we put a reader in SPD and then a reader on each side of autoclave. And so every time each reader, because each antenna is considered a location. And so if it hits this one, we know it's getting ready. When it hits this one, it's gone through. And so we have to make the assumption then that it's been through autoclave and we've had a new cycle. So.
Well, and again, we've talked about the improvements of especially the passive RFID technology for specimens. We just received, I think, from Derek or Zebra, some of the new M830 labels that we're testing. We're getting close to 20 feet of read range with a small little label now on a biopsy container, like on the lid. I mean, with antennas, I mean, it's pretty incredible. And even, again, against liquid, but we had some labels that were almost, the antenna was half on liquid, half off, that we were getting over 15 feet. So I'm sure with Walmart now and some of the work, it won't surprise me to see us having, lower cost thin labels that can be put up against liquid and red. So it's pretty amazing, just the improvements of technology and the use cases, and the cost keeps going down, and it's just opening up more applications. And again, the globe being a global standard where, these labels are, the Zebra readers, or, it's not a proprietary technology like early on where we had to do that RTLS and the Wi-Fi and the BLE. We can read the Walmart labels. We can take a Zebra reader anywhere, go into any store and hospital, and we filter that out now through our software. But it's just, from someone being in RFID for so long, it's just this, I guess, like AI too. It's kind of crazy. I don't know how far we can go, but it's almost getting maybe too good sometimes, because, especially, we're having to tune down antenna power and the readers now. I mean, because we just want that zonal tracking. We just want to get that RF energy as I walk through the door, and then I want to have an off mode till I pick it up again. But if we had one of the readers at 100, I could probably flood this whole room. But I just want to get this area, and that takes a little bit of work to kind of set up the configuration. But it's pretty exciting what we're seeing.
Yeah, we had a med device customer that we were using the older chip. I call older now, the M7 series, and we were doing some. It was a tag testing project, and so I had the manufacturer bring in some. Zebra doesn't have the autoclavable tags yet, hopefully. So they shipped me some of the 8 series chips, and all of a sudden we were reading 30 and 40 feet away. And again, as Gary mentioned, it was too good, because where we want to read is here. We don't want to read here. And so it's a very defined space that we want to keep it in. And so, but we can mitigate all of that. So we turned down we were using a handheld device and a table. And so we just turned down power and sensitivity to the readers through the antennas on the handheld and the fixed reader, and everything was fine. But again, when you're doing that, you just got to be cognizant of the tags that you are using. So one of the things that we do is, when we are scoping a new project, is we take time to understand what it is that we're tagging, understand the workflow, because one of the things that we don't want to do is add any steps to current workflows, especially in healthcare. When it comes to change, as I was talking to Mike earlier, I call it change, he calls it culture. And that's very true. They just don't like that change. So, yeah, we just got to be careful there. And once we understand all that, then we can come up with the appropriate tags, readers, and solutions.
Yeah, and to us now, the technology, 5 years ago, I was leery to put our company name on a project for passive RFID. I mean, it was, or you give a lot of caveats, but today the technology's here, and especially in healthcare and hospitals, our team's tagged over 200,000 assets now in hospitals. So we know where to put a label, what kind of label to put on an infusion pump, patient monitoring, wheelchairs, beds, anything. So now I think it becomes like this slide about the workflows and tying that in with software again and AI, and to get the benefits. I think we're at that level now where, we still have to talk about technology and, because there's been a lot of hospitals that have been burned in the past. We have to overcome a lot of times talking about the RTLS, the old Wi-Fi battery. I mean, sounds like Brian's made it work to a certain degree, but a lot of people come up and say, I hate batteries, I hate the replacement, and that, it's getting better, and it is a hybrid type solution, but it is what is your outcome, and tying in with AI and software now to really get those ROIs like you've got on that slide.
Right. Yeah. So any questions so far as hospitals dealing with business problems that would track and trace even on the med device side? Well, again, just as I'd mentioned earlier, in a hospital setting where they need that precision, they want to know where the patient is. Even with visitors into hospitals, we work with children's facilities where they want to understand visitors coming in. And so sometimes, mom can be there, but dad can't. And so with an active solution, they put a wristband on, or they actually have to be a heavier badge. But anyway, they can come in and then they will always know where they're at. That is an active tag. Now, I will say that with ASIP, we are getting really, really close. Some of the stuff that Zebra has now, especially in the warehouse with the ATRs, you're almost now getting a blue dot with passive. It's getting good. It's not there yet inside of a hospital facility, I would say. The difference being, and just to be blatantly honest, so a lot of infrastructure has to take place with passive, especially in a hospital. Whereas what you do get out of active, easier implementation, but a higher cost. And not only do you have higher costs, but you also have now management. So you've got to have that battery management program going on. And so what we hear a lot, and I know a lot of hospitals get frustrated with, is that if they don't stay on top of the battery management, what happens then is that battery dies, you lose visibility. And so I've heard scenarios where it's 2 years later, all of a sudden they go, we've got to go find this device. Well, all you have is the data from 2 years ago on where that device can be. And so, yeah, I mean, Brian, do you want to add anything to this on what you're seeing in the hospital?
Active tags, the scenarios that I shared, the IV pumps and then the wheelchairs. The IV pumps were easy because our biomed was already doing scheduled preventative maintenance, annually, those kind of things. So they worked that into their workflow. But while they're there, they check the battery, they replace the batteries if you need to. From a transport perspective, wheelchairs, that's still a struggle.
Yeah, we do hear that a lot.
No one really wants to take ownership.
Yeah.
And it's usually pretty reactionary.
You, Brian, got active tech wheelchairs?
Yeah.
Yeah, and again, when you guys started, 10 years ago, or passive wasn't there. It was a challenge on anything metal or liquid. And when we started out 7 years ago at the VA, we were putting those small tags on infusion pumps. We were only getting 12 inches of read range, the on metal. But with the next generation that came out overnight, we were in a biomed department at one of the Spokane, Washington VA. We went from 12 to 18 inches to 6 to 8 feet overnight, just with the new label. So it's like we continue, and now it's starting to make sense. Okay, 6 to 8 feet. Now I can, put antennas, wheelchairs and beds with that big I've got samples, but it's that classic silver line. We're getting 20 to 25 feet of read range now with passive on wheelchairs, beds, patient monitoring. It's like a 4-inch by 1.75-inch label. That's crazy. I mean, that's and I know Zebra. Mike Weinheimer said they're coming out with some new M830 chips in the silver line, I think, later this year. So I mean, I don't know how. It's going to just keep getting better and better. So
well, and going back to specimen tracking, and how we're tracking specimens is through chain of custody. And so we know what room it's coming out of. If there's another corridor where they can go, that traveler can run 2 different directions. So we'll put antennas to capture that. But you don't get the blue dot. But when that specimen does go missing, how do we find it? Well, at least now we're giving you, here's your scope. Instead of having to go out and go through trash bins out in the back parking lot, going through all the trash cans that they may have passed. Now we're giving you a small scope of where to go, and then you can grab a handheld device. And especially now with these new chips, since the read range has gotten so much greater, it's much, much easier now just to go ahead and grab the handheld and you can go right to it. Whereas before, you may have 4 or 5 people in search of that specimen and not find it still.
And with, they have active solutions for, wristbands and, badges. And I know the issue is they're reusable, they're expensive, and you have to clean them. And well, now Zebra has an RFID wristband that we've tested and are getting over like 10 feet of read range out of our antenna system. There's staff badges now that you can get with dual frequency. So you can get your HF, for access control, but they can put a UHF chip in there too to be able to be read through readers for staff tracking. So a lot of the RTLS, only kind of, use cases. I mean, there's still that, I think we're moving where passive is going to be able to do a lot of those. But again, hospitals have invested a lot of money and there's infrastructure. So, it makes sense to have that hybrid solution. I think, and I don't know how many use cases that Sonator ultrasound technology is pretty amazing we're getting down into inches, within a room, it's by sound waves, the technology. We've heard a lot of the hype and we've done testing and, it's a challenge in hospitals with the active. I think it's getting better, but in some cases, but you still have battery management and cost of tag and being able to just print just in time, like that application we're working on for specimens. We're integrating the Zebra printers to the Epic Beaker, their software. So, they're printing barcode labels today. So the nice thing is we're not really changing process. We're just dropping in a new desktop RFID printer, providing a new label with an RFID chip and antenna. And now we can even integrate to Epic Beaker. It's the similar barcode file, but we got some new commands to print the RFID chip along with the human readable. And so the process doesn't really change. And, you can do that for asset tracking too.
Well, and to continue on your question though, on where can you utilize active? One of the things, and MedDevice likes the idea of using active for surgical trays. But active is a proprietary software. And so for utilization to take place, full utilization, the hospitals need to be able to participate. But the other side of active is the cost. And so cost is, I'm hearing anywhere from $6 to about $50 per tag per month. And so, and I've worked with MedDevice for a number of years. And so I got a pretty good idea, it's millions of dollars that they are losing visibility to on these trays. But yet you still can't commercialize an active solution just from the sheer cost, because the cost is so much greater than the business problem itself. And actually that is why this format started last year. It was working with med device and then working with hospitals and then bringing them together and say, how can we solve this problem? And are we headed the right direction if we look at passive? And last year, we came away from this summit saying, yes, everybody agreed that, yes, we think we're all heading direct. We want it. Hospitals want RFID. They're starting to implement it. And so once they have it, and especially with the work that Kevin Warbeck's team is doing now, is using the platform that can consume all of these reads now, and then everybody can pull it as necessary. And so, Escalab, you bring a tray in, and then it hits a hospital's back door, SPD. Well, then you get that signal. It also goes to the hospital, let them know that that tray has been set in SPD. And vice versa, it's going out to Zimmer, Stryker, Medtronic. Wherever these pieces need to go to, that information needs to go to, this platform can now do that. And so we're really trying to focus on getting hospitals more adoption of passive RFID. So that way it's more of a global solution, which I was really excited when I found out that's exactly what Kevin and Caleb's team are doing is with Medtronic, is they're trying to push that as a global standard. And so doing that, it helps everybody. So, and it gives everybody a lot more data.
One question, trying to answer just now, would you say that with the advancements in passive technology and something like RATRs, so the investments in the infrastructure, fixed infrastructure, make that work, outweighs the investment needed, higher price active tags and maintenance programs to maintain that?
Oh, absolutely. Because if you look at it long term, yeah, it's a heavier lift from the get-go. But long term, and you're losing cost because look at the cost of a passive tag versus the cost of the active tag. But then you completely lose the battery management, which is huge.
Well, and if you guys were able to get an ATR that could mount on lower ceilings,
yes,
like in an OR, that's Zebra has this phased array antenna design that can read a big area, but that would be the holy grail, right? If we could put an ATR, like it looks like that access point sitting from the ceiling.
Yeah, look at Chad.
But if I could read all the tags in this area with just that one PoE cable, I mean,
yeah,
12 foot.
Those are the kinds of conversations that are happening now.
Right.
Yeah. Yeah. Well, I hope that's on.
Actually,
maybe I should go in there. Yeah.
That was a question I posed to Bob last night.
Yeah. So, but that's where technology is going. I mean, we've just seen, leapfrogs in just the last few years, but if we had just one reader and phase array antenna that could mount up, say in an OR, and read all the items on metal and small, hard to read.
Yeah.
Yeah. We are probably years away, but the good thing is if a hospital starts the tagging initiative and you start putting passive RFID tags on your assets and equipment, the readers and that'll all get better. So,
one, I know we don't have any life science in here today, but even liquid nitrogen, we're making a lot of gains being able to read there as well. They're coming up with new tags. This new technology is taking us places we haven't been before. So
yeah, there's minus 80 degree labels now for dry ice, for samples, and they even have adhesives that can bond at that level at minus 80. And then isn't liquid nitrogen minus 187?
Something like that, yeah.
But there's chips, they can actually read it. You can't apply
and adhesive that will adhere to it.
And adhesives that won't come out. So
yeah, frost doesn't cause an issue with applying, so.
Yeah. So.
Again, a lot of neat stuff happening.
Yeah. And you go walk through Walmart and you see look at the products, right? From the turtle wax to the, everything, tires, batteries, the label converters and tag people are coming up with real innovative new ideas and better performing. And when there's an opportunity, I don't know if we talked about it, but I think this year or last year, there were 60 billion passive RFID chips manufactured globally. I think that's right with the Zebra people. Aren't they saying like 2030 or something, we're going to be over 100 billion, or by 2028? So, yeah, it's with UPS now getting on board and the Walmarts and FedExes. And yeah, we're going to be over 100 billion chips. So, everyone's trying to get that next most sensitive and best read and get part of that market share. So for us, it's a beautiful thing. So.
And no more questions then. Thank you.
Yeah, thanks.
How y'all doing again this afternoon? Are y'all, how y'all feeling? Did y'all learn anything today? Y'all did? Yeah. I was, listen, I was wondering why I was invited. I told y'all that earlier, right? But first of all, I do want to thank Derek, for getting me out of my comfort zone, So I appreciate that. And I don't know the young man who left. I'm always in Zebra brand for a lot of reasons. And we had what did we have this week? We had Health Partners Advisory Council this week. So as talking earlier, Boyede was talking about orchestrating care. And then even the topic today, track, trace, and transform. Track, trace, transform, orchestrate, for sure. And I wanted to bring my backpack back up here so you could see it. And then I put on my tool belt, if you see that. I put on my tool belt today because if you don't take anything else, no matter where you are, no matter what you're doing as a partner or a healthcare organization or whatever, I want you to know this. Whatever technology that you're working with or designing or implementing, this is not where it's at. It's a backpack. We don't want anything else to burden us down or anything like that. So whatever you're doing, you have to make sure it fits on our tool belt. This is my tool belt. I actually have this, and I threw my little 301 on here too, my all-in-one. But the last February 14, 2017, as a clinician on the floor, I stopped pushing a while. When I work a 12-hour shift or a 14-hour shift, this is what I have. I have this. Zebra's come out now with a companion badge where it allows me to be hands-free. So as you are developing or implementing or whatever, and especially we're talking about track and trace, you have to think about those things. You have to think outside the box. So if you want adoption, those types of things, and I need to log into a different system just to track whatever, guess who ain't gonna log into it? Me. What I'm telling other clinicians as I'm out, I listen, I just barely got invited here today, right? I know nothing about track and trace, but what I do know is this. When I walk into an organization and I say I need to be able to track my stuff and locate it, I tell them to go back to the vendor, ask them if they got an application to drop on my device so I can just type in bladder scanner 101 because I'm looking for my bladder scanner. And then I might need Kate, so I want to just type in Kate's name. That is empowering me, right? So just want y'all to know that. So if you ain't got an app, I done told them, don't stress themselves about it. Take that back to the vendor. I just want to share a couple things with you real quick, just to talk about what we talked about earlier and just to close out the whole impact. Now, again, I cannot sell a thirsty man in the desert water. I can't. I'm not a salesperson at all. I tell stories. I talk about impact. I talk about value, right? And so that is what we have to focus on. When you're thinking about from a clinical perspective and our pillars here at Zebra, connecting the frontline worker, operation efficiency, intelligent visibility, all of that, that's the clinical piece of it when I talk about that. But what does track and trace? Y'all know I got to log in so I can tell you. I don't need slides, but I need slides to keep me on track. Y'all know that? That's what I need it for. But I want to get these key words to take away today because I did at least put a slide deck together, right? A couple things just to close out on what we talked about today. And did I stop sharing earlier? I'm talking to myself. Oh, sorry. Let me look at this. I should have been ready. This is what I'm talking about. Xavier said, always be ready. Now I'm letting them down. See what I'm saying? Be ready. How anything interesting today that surprised you? I do want to talk about Troy's presentation earlier on in SNG3 talking about Sonator. That presentation is what got me excited at HCAB because I promise you, I barely know how to spell track or trace, and I wasn't understanding it. And to see that it's not just RFID, or you can do RFID, you can use BLE and ultrasound and all of that. Y'all know my mind just started going. And that's where I saw the case study when it came to infection prevention and the young, I said it was a man. That was me being not nice. It could have been a woman that never washed their hands, but somebody never washed their hands. And that was a problem, right? And then clinically, what does that mean to me? And then also, I was trying to understand the impact. Greg, can you come help me find my calendar? I'm sorry. But that was the impact that I was seeing from that. And then trying to figure out, great, I can see the return on investment. Yeah, we can do hand hygiene. I can see the compliance, but how can I turn that into a dollar amount that the hospital is costing so I can talk to a CFO, right? I always tell everybody this, and this is who I am if you haven't figured that out. I have 99 problems, but workflow optimization is not one of them. Okay, understand that. And I'm looking for resource-wise, I'm looking to see how can I take what you're doing or the resources you're using and actually changing that back to taking those monies and using them other places. The second thing that I want to say was this. When Troy was trying to figure out what happened at the hospital that made them change their mind in the 11th hour, I already knew. It was an unretrievable specimen. And I wonder how much that's actually going to cost them in litigation. Lose my spleen if you want to. Lose it. Lose my biopsy that you took. My breast tissue, lose it that I can't get back. It's going to be called Cassandra's General Hospital. That's what it's going to be called. Lose it. Go ahead. So again, it goes back to that impact that I talked about earlier when I said the $50 billion. I have to talk about this stuff because Xavier makes me talk about it, right? The opportunity is there. I get it. Again, I don't sell, but the return on life is what, for me, is my driving factor. Everything you do is going to drive safer patient outcomes and change the patient experience, the clinician experience, and that really controls the bottom dollar, too, for everybody. Clinically, right patient, right medication or whatever you're doing, right time, right atmosphere. Trace and track or keeping all that is telling me I can now do what I need to do at the right time. That's what's it. Listen, Data, we always been knowing. We don't have a data problem. We got the data. Data is everywhere. Yes. Yeah. Data is everywhere. The problem is the application. Moving the needle, moving from visibility to velocity, visibility to velocity, to moving, the action. And so really taking that data and then applying that, when we talk about adoption and how do we move the needle, how do we do that? That's what you have to do. Yes, we need use cases, but being able to prove those values. So think outside the box. Troy said it earlier when he was talking, is pain points. Listen, shout out to my healthcare team in here. I love them. They love me. They everywhere. They do. I mean, y'all can't tell I love working with them too. I really do. But I tell them, I sat on stage last year at sales kickoff, and I told them, if you go in to solve the problem, the pipeline will take care of itself. Solve the problem. Take your blinders off, solve the problems. We are here to solve problems. So if you solve the problem, everything else will be added to. You have to think outside the box. You have to think outside the box. So what I'm going to tell you is stop thinking that, oh, we've never done it this way. Y'all already know, y'all have kids at home or a husband or a wife. You go and you want to change the way we've done things, that we don't want to do it. We absolutely don't want to do it, but we know, or whoever's asking for the change, we know that's the best change. Do you understand what I'm saying? So think outside the box. Design technology that is really going to keep us in this clinical mobility phase. Track and trace. I don't want another instrument. I ain't want to log into a system because I'm not going to do it. I'm just not going to do it. Middleman, didn't go to school for that. I need to stay mobile. We need to create technology that's going to support and not add additional burden. There's a lot of opportunity out there to really help that margin that went down from 7% back from 2019. I never say people don't have money. I don't. Where is it? It's misplaced. They have it. They have resources that we're wasting. So it is our responsibility to help them, show them where they are. So, and if you need me, I'm here for you. I am Zebra CNIO, but I'm yours too. Whoever you are, you're a Zebra customer, I got you. You can call me about anything. Ain't got necessarily have to do with Zebra. Got a problem? Let's see if we can work it out together, because we're about success around here. Okay? Thank you.